Welcome to this meeting of the Health and Wellbeing Board. I would like to inform those present that this meeting is being webcast live and will be capable of repeated viewing. It may be worth explaining that voting members, including health partners, are in attendance in the chamber to take part in the debate and to make decisions. Some officers and partners may be joining the meeting via Microsoft Teams. Are any members in attendance as substitute today? Yes, please.
Which one do I do? Oh, no? Oh, okay. Hi, everybody. I'm Monica Fletcher. I'm the Deputy Chair of the new Integrated Care Board Cluster, and I'm representing Ian Smith, who is the Chair of the new Sussex and Surrey ICB Cluster. So, thank you.
Thank you. Any other substitute? No.
Hello.
Hello. Sorry. Who's there?
Hi, sorry. My name is Jenny Priest. I'm the Deputy Director for Strategy at University Hospital Sussex, and I'm here instead of Peter Lane.
Thank you. Any more? No.
Yes, David Kent. I'm representing Hannah Yalden on behalf of East Sussex Fire and Rescue Service.
Okay, thank you. Any other substitutes? Thank you. Do any members wish to declare any interest in relation to any matters included on the agenda? Okay. We have no part 2 item today, so the press and public won't be excluded. Does the board agree to approve the minutes of the meeting on the 16th September 2025 as a correct record? That should have been provided to you. Does the board agree? Thank you. I would like to open the meeting by thanking all the colleagues that supported last month's Health and Wellbeing Board Development Session. It was great to bring together board members with other colleagues who are active in the leadership of our health care partnership and start our work around the development of the board and the refresh of our health and well-being strategy. I was encouraged by the results of our review of board effectiveness, that partners felt we were good at delivering our statutory duties as a board. It was also positive that members felt we were effective at creating a strong sense of place and ensuring our delivery had a strong local focus. I think this reflects our recent work around the Health Council Survey, our GSNAS, and the evolving work of our local integrated community neighborhood team partnership across the city. So I'm pleased that this work is part of our agenda today as we look at the progress on our shared delivery plan objectives. It was also important that we got constructive feedback that there is more we can do to support our joint working and strategic planning to improve the health and well-being of the local population. We have the Better Care Fund on our agenda today. As chair, I'm keen to see us continue to improve our leadership of this important fund that should drive local integration, ensuring that our plan and associated investment is driving improvement in local health outcomes and enabling the new neighborhood health reform. In our recent board development session, our work together on assessing our board effectiveness led naturally into us considering the latest data we hold on the health of our population, of our local population, and how this should inform the development of our joint health and well-being strategy. There were some consistent themes that emerged from our discussion on the data. One of these was the need for our strategy refreshed to enable a more focused approach to targeting key population health priorities. There was a board agreement that our strategy should have strong focus on prevention, local health inequalities, and that health and well-being boards are uniquely placed to focus on the wider determinants of health. I know that colleagues will be using all the valuable feedback collected in our development session to produce a more detailed scope for our strategy refresh. And a model of board development for us to consider and work on at our next Health and Wellbeing Board development session in March. I would also like to take the opportunity to welcome Monica Fletcher, OBE, to the board. Monica is the Integrated Care Board Deputy Chair and will replace Stephen Lightfoot at the board. Monica brings with her a wealth of experience, having originally worked as a nurse and later as NHS manager and an academic. I'm sure she will be a valuable addition to our Health and Wellbeing Board. So welcome, most welcome. Finally, just to note that there is a minor change to today's agenda. I've been asked to take item 32, Shared Delivery Plan Progress Report, ahead of item 31, Better Care Fund Assurance against better BCF delivery. Column, please. I'll hand over. The Democratic Service Officer will now take over the call over. And I ask that members indicate those items they wish reserved for discussion by calling them as appropriate.
Thank you. So items potentially for discussion today. Item 28, Violence Against Women and Girls Strategy and Action Plan. Item 29, Local Safeguarding Children's Partnership Annual Report. Item 30, Joint Strategic Needs Assessment Programme Annual Report and Update 2025. Item 31, Shared Delivery Plan Progress Report. And item 32, Better Care Fund Assurance Against BCF Delivery. Okay, thank you. That's all items on the agenda have been called and will be discussed.
Okay, thank you. Public involvement. We have no public questions today. And member involvement, we have no member questions today either. So I would like to invite Anna Clark, the Strategic Commissioner for Violence Against Women and Girls, to introduce this item, please.
Hi. So obviously we are here to introduce the item around violence against women and girls. This really is for the Health and Wellbeing Board to note strategy. Strategy obviously covers violence against women and girls, which covers it's an umbrella term for a number of serious violent crime types, including domestic abuse, sexual violence, harmful practices, exploitation, and stalking, as well as online abuse. This strategy was agreed by Cabinet in January 2025. It crosses with multiple strategies in Council, including the One Council approach, which is obviously part of the Council plan, and that is reflected in the work plan of this strategy. So therefore, there is an onus on different partners within the council, that are partners to the council and council services, to contribute to the delivery of this strategy's work plan. There are 4 priorities within this strategy. One is around coordinating response, one is around prevention, one is around supporting survivors, and one is around holding perpetrators to account. The national strategy is due to be published on Thursday. Our impression is that our strategy mirrors the priorities within the national strategy. And in terms of the work of the Health and Wellbeing Board, it is just for note that violence against women and girls is a significant health inequality. It's a cause and effect of health inequality. And our local data highlights that we have high levels of people at our high-risk multi-agency conference for high-risk victims. 39% have a health or mental well-being issue. And again, we have the emerging theme in our domestic abuse homicide reviews and death reviews, where we are seeing increased numbers of death due to suicide. And that's my overarching view of the strategy, but I also want to say I am happy to take questions.
Chair, with your permission, I'll just lend a political view from myself as the Cabinet member with the responsibility for this area. So just to say that our definition in the strategy, the government's definition, and that of the previous government were very clear that whilst the strategy is called VORG and relates to crimes and incidents that are violence against women and girls, that our strategy involves those crimes against everyone. So they are inclusive of everyone. And then to ensure adequate political leadership, because my role encompasses children, this, community safety, so it's quite broad. We've also appointed Councillor Sam Parrott as our lead member for VORG, who does a lot of the effort involved in making things happen. So she was very much a leading role in the 16 Days to End Violence Against Women and Girls campaign this year. I think strategically the biggest challenge that we all face, but just in terms of this strategy, is to move resource more from the crisis end towards the prevention end without destabilising or risking the adequate support for those very high risk cases. So the people that Anne outlined, those people that are at risk of serious harm or death. And I think, we mostly perform well. And I think another area that we have, my understanding is that we need to improve on, as well as that we do have repeat merit clients. So that's women coming back around that system, having been risk assessed and worked with. I'd just like to say, as political leadership, we're determined to pull every lever we can to support the government ambition to halve domestic abuse by 2030. Some examples of work we've done over this year in aid of that are implementing organisation-wide training. So that's not just for people working specifically with people experiencing domestic abuse and sexual violence, but everybody. And we've also supported the Smartphone Free Childhood campaign. And the relevance of that to this issue is that 80% of girls surveyed in 2021 by Ofsted said that either a friend or themselves had been sent unsolicited explicit content through their smartphones, and furthermore had been pressured to send content themselves. So I hope that gives a kind of good political overview of the state of play from my perspective. Thank you.
Thank you, Anne, and thank you, Councillor Danielle. I think it's the decision to include everybody is something to be held, so thank you for that. Do you have any questions or comments? Yes, please. Tanya.
Thank you so much for the report. It is very welcomed, and as you know, very, very important part of our population health outcomes and certainly looking at addressing inequalities. One of the key things I believe we heard as a board from the health counts data particularly identified an increase in suicide rates in women and girls. So I think it's notably a very important subject, and certainly in terms of the action plan. And I'm just sitting beside Nikki Lang as the Director of Public Health, and one of the areas we also identified through the data is the importance of women's health and the programs that we offer in the city for girls and women. Yes, inclusive of everyone, but there are some targeted areas that we do need to focus on around women and girls. So I think the question I just wanted to ask was particularly notably in terms of the outcome measures and the process, what would you say would be maybe 2 key outcomes you would be looking for, given that we now have the strategy? How can we as health partners work with the local authority, the VCC sector, on 2 priorities, given, there are a lot of priorities and we just want to focus our efforts?
Thank you for that question. It's really important. I think the 2 main priorities would be to ensure routine inquiry is happening across health services, and also because that lends to early intervention and prevention, and also our efforts to tackle the emerging trends of suicide. And so in terms of how we work with this agenda, we need to think about domestic abuse prevention is also suicide prevention. So therefore, some of the work going forward that we are developing actually at this time, in real time, is for our MARAC, which I mentioned is the high risk forum that we have weekly to reduce risk. We, on our MARAC Away Day, the MARAC membership, agree that the MARAC is a vehicle to refer people with suicidal ideation. Our services have received suicide, so these are all the providers who are working with victims of domestic and sexual violence, have attended training on domestic abuse and suicide awareness, and that was funded by Public Health. We're very grateful for that, but feedback from that training is it's been brilliant and they've really found it useful, but actually what we need to be able to do is hold people, so it's like mental health, first aid sort of work really, to hold people when they are disclosing they're suicidal. So our efforts around obviously links to suicide prevention strategy as well, but it's obviously very important because we're seeing this emerging trend. I have to just give you some data which might clarify that. We have got 6 domestic abuse related death reviews in progress at the moment, and 3 of those are suicide deaths. So that's what part of our work to tackle that, but I would like to just say that I think in terms of your question, that is also very important.
Sorry. Thank you. Do you have any more questions or comments? Yes, please.
Could you just remind me what the MARAC acronym stands for, please, and advise whether there's a permanent member representing the voluntary sector on that group, and if not, then what's the best way in which we might inform that group or be privy to some of the outcomes that we might support to make sure that these high-risk cases get that holistic package of care?
Yes, thank you for that question. Yes, multi-agency.
Sorry, that's your microphone.
Oh, sorry. I thought I had a question. Sorry about that. So it stands for Multi-Agency Risk Assessment Conference. We have that meeting every Thursday at Brighton and Hove. It's quite high volume. We worked with 903 people between July 24 to June 25. Basically, in terms of the voluntary sector, it's obviously people who are risk assessed as high risk are sent into that meeting. So it's not for all victims, it's just for those at very serious risk of harm. Voluntary sector is represented by a wide range of people, including CGL. We have victim support there as our main service, Switchboard attend, Rise attend if they refer a service in. We also have on occasion had the International Women's Network there, Mankind will refer in male victims if they're working with them, but actually any service can refer somebody in, and we are doing additional training with the voluntary sector. So the voluntary sector agencies who are working with communities also have the understanding of how to refer in. It's not necessarily that they have to be a standing member, but obviously we would, very happy to disseminate information about our multi-agency partnership training, because obviously not everybody is at high risk, but actually we want to drive through the work on prevention as well, so we identify people at an earlier stage of risk.
Thank you. Any more questions or comments? Yes, please. Yeah? Online. I can't see online, sorry. All right. Online. Who is it?
From Outwatch.
Alan, please.
Thank you, Chair. Can you hear me okay?
Yes.
Yes, okay. So I just wanted to say thank you for the strategy. I think it's very much needed, and it's also very well written. It's very clear what the objectives are and what the need for the strategy is. So I think you can be commended for producing such a clear strategy. I think it highlights the need for extra focus on our women's hubs, which we'll come on to later, which shows that we're a little behind on developing those. I know they're not specifically intended for maybe for victims of domestic violence, but having a hub where women can go to get support and help is really critical. So I think that just shows why the focus on that is needed. I was really interested in the lived experience group that you reference in the strategy. I just wondered if you could tell us a little bit more about how you intend to ensure the voices of those people continue to be fed into the strategy as it develops. Thank you.
Yes, again, thank you. So there is a board, which is an board, and we work with that model.
Thank you. Any more questions or comments? Yes, please.
Thank you. And I too would like to commend the report. It's a fantastic read. My background is research and data, and I'm always really interested in the data and how it's collected, and if this is a true representation of the issue. I just would like some reassurance, or some assurance really, that what we're seeing is the extent of the issue. It's the hidden issue underneath, and do we have any idea about the data that we're being presented with and the number of cases, and is there anything we could work on in the future together? Thank you.
It's restarted, it's fine.
It's definitely on. Okay, yes, data is very important, and we are looking at actually improving our data performance framework, because we have data from the police. Obviously, we all collects data in the same format, but we do have data from our MARAC, which is obviously our own data. We're monitoring that, and we have the service data from services. So obviously we monitor that on a quarterly basis, but ultimately there are lots of people who are not using services and actually presenting in other parts of the partnership, including health, which is why I referred to routine inquiry. But we need to have a mechanism for collecting that. Also where people have presented maybe in A&E services, and that's the underlying cause of why the presentation has happened. So ultimately, that is something we would like to develop in a more sophisticated way and welcome opportunities to work on that, to develop that further.
Thank you. That's a fantastic response, and I just think it's something we ought to be thinking as a board moving forward in the future is how do we collect that data, and if there are parts of the system that are not collecting the data, or it may look that it's lower than maybe expected, what we could all do from the different aspects. So thank you very much for your answer. Thank you.
Thank you. Any more questions, comments? Online? Yes, I think I can see one online. Is that right? Yeah. Okay. So do members agree the recommendation to note the Preventing and Tackling Violence Against Women and Girls, Domestic Abuse and Sexual Violence Strategy 2025-28, and progress in delivering the action plan for its implementation, and support the proposed role for health partners in supporting delivery of the strategy as set in section 2.8 of this report? Yeah. Okay. Thank you. Thank you, Anne, and thank you, Councillor Danielle, for your reports. May I now call on Dave Boston? Dave Boston, please. I would like to invite Dave Boston to present report on Local Children Safeguarding Partnership annual report.
Thank you, Chair, and thank you for the opportunity to present the Brighton and Hove Safeguarding Children Partnership annual report for 24-25 to board this afternoon. I'm Deb Austin, I'm Corporate Director for Families, Children and Learning at Brighton and Hove City Council. I'm presenting this report in my role as one of the 3 designated safeguarding partners and as Chair of the Brighton and Hove Safeguarding Partnership Group. We've got some slides. I'm going to whip through them at a pace, if that's okay with you, Chair.
Yes,
so in terms of what our annual report for last year covers, it gives an overview of activity around learning, improvement, evaluation, assurance and impact. It also outlines the partnership's business plan. It contains partnership updates and contributions during 24-25. Sets out our governance and structure, including the new multi-agency safeguarding arrangements, and outlines the collaboration with our pan-Sussex partners on learning and development, policies and procedures, and quality assurance. For today's focus at board, I'm going to run through some of the key headlines and work streams from the annual report. Next slide, please. So just in terms of a bit of some metrics for our city, we've got around 46,500 children and young people under 18 in Brighton and Hove. That's a mid-2023 estimate. What we've seen over recent years is declining numbers of children in our schools, but an increase in the number of those eligible for free school meals at 26.9%. This is above the national average. 16.4% of pupils are exposed to a language other than English at home, and 18% of pupils in our schools receive SEN support. Again, this is higher than the national average. We've seen an increase in children with education, health and care plans and those electively home educated. And there is an issue for us as a city around persistent absenteeism from school and are not in employment, education and training for our 16 to 18-year-olds. Our rates there are unfortunately above the national averages. On a more positive note, the suspension rates for children being excluded from our schools are below the national average. Next slide, please, Giles. So in terms of our safeguarding snapshot, I suppose the headline here is that there are just under 20,000 initial contacts to our front door for families during 24-25, and these resulted in 3,222 referrals into children's social work services. We had 200 children subject to a child protection plan. Our rate per 10,000 is above the national average. We had 289 children in care, and that's excluding our unaccompanied asylum-seeking children, of which there, if we add them in, that comes to 334. 364 care leavers aged between 17 and 25 were supported, and that includes 148 former unaccompanied asylum-seeking children. In terms of first-time entrants to our youth justice system, that was 42, down from the previous year. And with regards to our family hubs, which is where early social care intervention is provided, there were 200, just over 2,600 referrals, with 675 children open to the hubs across the city. Next slide, please. A requirement of Working Together 2023 was for all safeguarding partnerships to review their multi-agency safeguarding arrangements. That's what MASA stands for. And within Brighton and Hove, our new arrangements were published in September 2024, and they're currently being reviewed during Q4 of 25-26, as required by the Department for Education. Our new multi-agency safeguarding arrangements involved us developing a new structure, formulating closer working relationships with safeguarding partnerships in East and West Sussex, and putting in place a strategic oversight by a Pan-Sussex safeguarding children's executive. And that is made up of the lead safeguarding partners across the 3 areas that cover Sussex. The membership includes the 3 local authority chief executives, the Sussex Police Chief Constable, and the chief executive of what was then NHS Sussex, and going forward will be the chief executive of NHS Surrey and Sussex. The multi-agency safeguarding arrangements review also addressed the need for education to be more formally involved in the safeguarding partnership arrangements as the 4th partner, and the development of an education safeguarding subgroup, and that includes head teachers and educational professionals from across our city. In terms of the Pan-Sussex approach, that was very much about expanding regional working whilst retaining a place-based focus. That's enabled efficiencies around working practices and some economies of scale, for example, commissioning training on a Pan-Sussex basis. And the new arrangements have expanded our response to national learning and reports, including those around child sexual abuse and racism safeguarding reports. Next slide, please, Giles. So I don't propose to go through this. This is just giving an overview of the Pan-Sussex and local safeguarding structures. Next slide, please. And slide 7 kind of brings that down to a more place-based level for Brighton and Hove. It sets out the structure of our local safeguarding partnership and details the subgroups and how the governance arrangements work. Next slide, please. So this slide, I suppose at this point to kind of highlight that pages 16 to 30 of the annual report covers how our partner agencies have worked together to deliver the partnership's priorities. And for 2023 to 2026, we have 4 main priorities. That's around partnership engagement and accountability, safeguarding children and young people from violence and exploitation, reducing neglect, and lastly, supporting children's mental health and emotional well-being. Those priorities have been informed by learning reviews, legislative changes, management information and data and quality assurance activity. If we just kind of have a little bit of, sorry, next slide please, Giles. A couple of examples of progress that have been made on those business priorities. So priority 1 around partnership engagement and accountability. Our multi-agency safeguarding arrangements, as I mentioned earlier, have focused on how education could be more involved in the partnership arrangements. There's a recognition that our schools and colleges are uniquely placed as they have prolonged and daily contact with children. And within the Brighton and Hove Safeguarding Children Partnership, we've established an education subgroup which has links into the local partnership group and the Sussex Safeguarding Children Executive. There's been a focus on cascading learning from local and national safeguarding practice reviews throughout education networks and forums, and promoting safeguarding awareness training in schools and colleges across the city. Next slide, please, Giles. With a bit of a focus on reducing neglect, which is our priority area number 3. During 24-25, we've developed a new multi-agency neglect strategy. We've stood up neglect forums, which are opportunities for professionals to meet up and discuss specific cases where neglect is a factor, and developed a neglect champions programme. These are multi-agency champions that support practitioners and promote use of the assessment tool where neglect is a concern. Okay, next slide please, Giles. So a bit of a focus now on learning and development during 24-25. A key role of our partnership is around delivering and commissioning multi-agency safeguarding children training and disseminating learning from local and national safeguarding children practice reviews. A couple of metrics here. So during 24-25, 58 separate courses were delivered, and they were attended by just under 850 multi-agency practitioners. Safeguarding Fortnight was held in November 2024 with workshops and conferences on hidden harms, and that had just under 300 Brighton and Hove participants. There was also an anti-racist practice and allyship conference attended by just over 100 people, with a focus on amplifying Black and global majority voices, intersectionality with SEND, stroke neurodiversity, and the importance of allyship. Next slide, please, Giles. In terms of local safeguarding practice reviews, the partnership has a case review group which is responsible for the management of all rapid reviews, local child safeguarding practice reviews, and looking at national learning and arranging for dissemination to all agencies across the city. In terms of there's a couple of examples there of some practice reviews that took place during 24-25. Child Zeta had a focus on exploitation, violence, contextual safeguarding, identity, race and culture, and Baby Aspen was around neglect, trauma and domestic abuse. There's the learning from these reviews was around the importance of multi-agency support, the challenges in safeguarding and the impact of trauma and adverse experiences. Next slide, please. Evaluation and assurance. This is an absolutely key part of the Safeguarding Children's Partnership remit. It's how I, as a designated safeguarding partner, have a line of sight on how the city is working together to keep children safe. Within the local authority, we had children's services inspection in March 2024, with the report being published in May of that year. It was a very positive inspection with outstanding overall judgment. What was really good to see in that inspection report was the acknowledgement of the highly effective and embedded partnership working, which is modelled by the Brighton and Hove Safeguarding Children's Partnership across all levels, and the report highlighted that children benefit from this collaborative partnership work. And finally, in terms of moving forward and next steps, what the annual report sets out is kind of the work programme for 25-26, some highlights from that. Sorry, next slide please, Giles. Are the development of a Pan-Sussex learning and development strategy, so partnership work with the East Sussex and West Sussex Safeguarding Children's Partnerships, the publication of the Child Epsilon and Baby Aspen local child safeguarding practice reports, and setting up the associated learning events with those, a review of the child sexual abuse strategy, a redesign of the partnership's website, development of a new quality assurance framework and data strategy, and I mentioned earlier the evaluation of the multi-agency safeguarding arrangements, which is happening currently. Also, an important facet is the development of the Young Scrutineers programme and the co-production of an annual report written for children and young people. I think that's it. I think there might be one more. Slide 13, is there? Slide 15. I think just gives us the links there to the annual report, and I think I just wanted to highlight our first Children and Young People's annual report has been published. That's available on the Safeguarding Children's Partnership website. And as I said, future reports will be co-produced with our Young Scrutineers. And just as a closing note, really, to kind of say to board that the annual report demonstrates the partnership's commitment to continuous improvement, multi-agency collaboration, and safeguarding children and young people in Brighton and Hove. Thank you.
Thank you, Austin, for this report, which has a lot of positive things. Great work being done. Do you have any questions or comments? Yes, please, Lucy.
Hi, Deb. Yeah, thank you. Very comprehensive report there. I was just looking on priority 2 there with the Family Hub service and seeing that schools refer young people with an attendance rate of less than 30% for multi-agency discussion. I mean, as there are so many reasons behind non-attendance at school, I'm just wondering whether 30% is too low a rate and that should be looking at intervention at a higher rate than that. That's, 1 in 3 days school attendance, isn't it? 30%. Thank you.
Thanks, Councillor Helliwell, for your question. Yes, 30% attendance rate at school is extremely alarming. And what we do know in Brighton and Hove is that we do have an issue with school attendance. We're significantly below the national average around that. I suppose what I would say is that's not the only intervention around school attendance. So priority 2 is linking that into what we know is that school's a protective factor, and what we know is the links that can be for our older children, so children in secondary school, particularly around susceptibility to exploitation in all its forms around that. But in terms of that being, so you wouldn't only get a support service if you hit 30%, I suppose is what I'm saying. What we know is that those that are below or 30% are the ones that we would be most concerned about, and hence the reason that we would be looking at that through a contextual safeguarding stroke exploitation lens for older children.
Yes.
Thank you. Sorry, and then on priority 3 then with the neglect, which great that it's overall good, and I see that you've got a neglect steering group that's going to provide that tailored performance management, and I was wondering if you could give us a little bit more in depth on that, as obviously chronic neglect is just harmful for somebody for the rest of their life, really, isn't it? Is this targeted at managers or at practitioners? And are we making sure that good practice is cascaded through the system? How is that being shared? Thank you.
Thank you, Councillor. No, you're right. Neglect is a continuum. Actually, if we want to make a real difference, it's around recognising neglect when it first manifests rather than only responding when it gets to that chronic state. So this is, the focus on neglect is about working with all professionals across the city, so not just those, not just social workers or our family hubs, but health visitors, with teachers in school, professionals who see children, have contact with children, and enabling them to recognise neglect at an early stage. The steering group, so there's a strategy that's been developed over the course of 24-25. A lot of work has gone into rolling out a graded care profile, which is a toolkit that enables people to recognise neglect. Also to do a benchmark on things, because sometimes it's about drawing a line of, okay, this is what's going on now, what's happening in 2 months' time, is it still the same, has it deteriorated, is it getting better, around that. That's been, the champions that have been put in place are multi-professionals, so it's not, again, not just social care workers, so not just council employees, in order to, I suppose the adage is safeguarding is everybody's responsibility, and the Brighton and Hove Safeguarding Children's Partnership is about how we enable and empower all professionals, whether they work in schools, whether they're in the police, whether they're health professionals, whether they're social care professionals, to recognise neglect and respond to it in a robust way around that. In terms of the forum, they're very much for practitioners. So that is an opportunity for people to come together and say, this is what is going on, have a case discussion around that. So almost in a group supervision environment. Thank you.
Okay, thank you. Any more questions? Comments? Tanya?
Thank you, and thank you, Deb. As members of the ICB, we have been working hand-in-hand partnership, plus obviously representing the NHS organisations. One of the areas that we are going to be doing a lot more work in, so this is probably more of a comment and a question at the end, is improving the access to oral health, and certainly looking at mental health access, because we recognise these are two core areas when you look at the report in terms of the mental health needs, the dental, the cavities and extraction as a result, but also in terms of the mental health needs of more vulnerable children, particularly as we know in some of our areas. We have high areas of deprivation intersecting with ethnicity as an area, but also in terms of self-harm, another area that obviously we need to do more from in terms of early identification. So I suppose the question is, are there any gaps, particularly that as partners we can be doing more in terms of the prevention piece, given that we're working now in a neighbourhood way where we're starting to work more closely together with a neighbourhood hat on, so we're bringing family hubs working alongside the ICTs, and there are members here who also are supporting some of that work, the volunteer sector and others. Is there anything more we can do that could, help us to improve?
Thank you for your question. In short, the answer to that is yes. There's always more that we can do. For me, the key bit is around the recognition and then the response of that, which is why there is this emphasis on the graded care profile toolkit, and empowering all of our workers, regardless of their professional background, to feel confident in that space. By the time it becomes something that is brought, for example, to a social worker's attention, going back to Councillor Helliwell's question earlier, you're already down the route to chronic neglect. So it is very much around that early prevention piece. It is around working together. I think there's an opportunity with the new children's social care reforms and the expectation there around early family help and multidisciplinary teams around being able to bring in people like health visitors, for example, school nursing, teachers into that forum, and supporting them to be confident in their recognition of what neglect looks like. Unfortunately, oftentimes social care only know about it when they're told about it. They see a very tiny proportion of the number of children in the city, so it is around how we work with those partners who see children day in, day out.
Thank you. Any more questions? Yes, please.
Not so much a question, Chair, but a comment. I see the number of children have actually decreased. Is it 2,000 approximately? Obviously, I'm looking at public health here, but projections forward, what is that looking like over the next few years? Because it is a declining number of children, but it seems like the needs are going up. So I would just like to get a feeling of that. And just for my information, but to, again, to embellish, I love this idea of the young scrutinisers and how you recruit them, how vibrant are they? Are you looking for new people to join that group? Who are these young scrutinisers? Because I think it's a fantastic thing that you do there. So thank you very much.
Thank you for the question. It's my favourite, my favourite statistic here. Between the 2011 and the 2021 census, there was a 6% drop nationally in the number of 0 to 4-year-olds in the country. We know there's a declining birth rate. Within Brighton and Hove, that drop was 22%. So that gives you that indication of actually the number of children and young people in our city is rapidly declining. In a different role, that's something that has been a challenge around school placements in the city. We have far more school places than we have children to fill them. What that's caused by, I think the biggest issue around that is the cost of housing in this city. And what we know is that many families can't afford to live here. We know we've got a housing crisis in the city in terms of people waiting. We have large numbers of children living in temporary accommodation. So I think all of those things coalesce together to make it really difficult for families to remain within the city. In terms of the projections going forward, I think I'm not a public health specialist and I don't want to put my Director of Public Health on the spot here, but I think our projections around schools show that that is continuing to decline, and we've taken that data from NHS data on children who are registered with GPs as babies now. So as we know that they're not going to be there kind of going forward. And as I say, nationally, we've seen a drop in birth rate, and that doesn't seem to be shifting in any other direction on that one. I'm going to put her on the spot now. I've got Sarah Smart, who is the partnership manager on the call, who can help us out with the question around recruitment of young scrutineers. Sarah, I'm not sure if you can hear me or not. Yes, you can.
I can, yeah.
Thank you.
Hi, as Deb said, I'm the partnership business manager, and I'm supporting this meeting today. So yes, we are in the very early stages of recruitment for young scrutineers. I'm hoping everyone can hear me okay. We are looking to recruit from some existing forums, but also we are going to advertise using our community and voluntary sector partners for children and young people aged from 16 up to around 22 years. We're in the process of doing the recruitment advert at the moment. We're very keen to not call things adverts and applications or interviews. We're looking at them as being they're going to be getting to know you and getting to know us meetings, and the plan is to have 3 or 4, because we'd like to have a cohort of young scrutineers because we think that could provide some peer support, and we're also going to link in, we're kind of running similar in each of the 3 areas, so hopefully we'd have a cohort of about 10 to 12 young people that would like to do this. In other areas, they have had kind of like a 2-year tenure between the ages of sort of 16, 17 up to around 19, but we'll be very much led by the young people as to how long they feel they can commit to this. And we have a kind of in progress at the moment, we've got a kind of 12-month plan so that young people know what we'd like for them to be involved in, but also so they can plan their life outside of the partnership as well, because we don't want to impact on them being young people as well. So we kind of wanted to sort of make it realistic for them, and we're going to co-produce that kind of plan. We've got some ideas that we'd like, but we obviously want to encourage them to have ideas as well. I'm not sure if that answers your question.
Absolutely excellent, thank you. I know that we ran an event earlier on in the year with young people, and they are more challenging. They ask the questions that perhaps we won't as adults.
Absolutely.
So it's brilliant to engage them, so thank you so much.
No worries.
Okay, thank you. Do we have any more questions, any comments? Yes, Councillor Hollow.
Sorry, me again. Looking at the 289 children in care, and I know a big focus is to keep with that kinship care so they can keep contact with their families if that's obviously appropriate. But I know another area that that you were looking at was that the children that are housed outside the area, you were looking at ways of trying to bring them back into the city. I'm just wondering if we managed to make any progress on that. Thank you.
Thank you, Councillor. Yes, we have made some progress in that area in terms of we've recently opened a full-time residential unit in the city called Rainbow Lodge that is providing now a home for, it will be 4 young people, so 4 children in care who have complex disabilities that have been placed significant distances from the city because of the level of their needs. So we've been able to bring them back into the city for education and obviously to be much, much closer to their families.
Thank you. Any more questions? Yes, please, comments.
It's more a comment really, sort of coming back to what Tanya was asking about how we work together on this, and I'm here to represent the sector. I can talk about my own organisation, but I think it's fairly a common thread throughout organisations that we have a whole system for managing our safeguarding, and we have records of concern which that is added to daily. And that's always reviewed by one of the senior managers, but that starts where things are never going to meet the safeguarding threshold, but it starts to build a picture, and so if things do escalate, we've then got that history of where, what's happened before, and they're often shared with other professionals working with that child or young person. And we also provide safeguarding training predominantly to the sector, but to businesses as well. And we've recently introduced a course for trustees because it's really important that the trustees understand their responsibilities in safeguarding as well. And that's been really popular, which is really positive because there's just more and more of people in that position now who understand what needs to be happening.
Okay, thank you. Any more questions or comments? Yeah, I just want to thank Dave Austin very much for this report, which has a lot of positive things. I think it's very encouraging to know that our partnership is well embedded within Brighton and Hove. The services are all embedded together. And also, it's also encouraging, or let's say it's a good initiative to know about the multi-agency for neglect, especially as we know how important, neglect is connected to safeguarding issues and how fast, they can reach the services. So that's very important. And it's also encouraging to know that the expulsion rate from schools is below national average. I was just wondering whether there's anything special that we are doing to achieve these results, which other areas could learn from. That's one. And another thing is about the young scrutineers, which is also a good idea, but I was just wondering whether it's possible that when you recruit, that we are careful, I mean, we give importance to diversity in terms of gender and age and also culture, diversity.
Thank you, Chair. From your first question around the low exclusion rates and why is it so low, we are very lucky that we have a really inclusive education system within the city, in particular across our secondary schools, which nationally is where most fixed-term exclusions occur as young children get a bit older and perhaps a little trixier around that. All of our schools, but in particular led by Patcham High, who John McKee there chairs our secondary school partnership. Patcham High hasn't excluded a child for countless numbers of years, and they are the embodiment of an inclusive ethos, and that's mirrored across our other high schools within the city. So they recognise that children will at times find school a difficult place, but they'll put, rather than exclude, they'll look at actually how can we take an inclusive approach to these behaviours and support that child to remain within school. So we're very proud of that and very grateful to our school system for kind of really championing that inclusion agenda around that. In terms of your question around the young scrutineers, absolutely, I think the partnership is really cognizant of the fact that our young scrutineers need to represent the diversity of the communities within Brighton and Hove. We want them to be the children that we are tasked with providing effective safeguarding for. So yes, that will definitely be something that we will be factoring in to, I hesitate to call it a recruitment process after what Sarah said, but in our trying to get them on board to work with us and help us.
Okay, so do we have any more questions, any comments? Okay, thank you very much for the report, for the great work, and thank you everybody for all the great questions, which was very informative. The next thing is, does the board agree to note this report? Okay. The next item on the agenda is Joint Strategic Needs Assessment Program Annual Report and Update 2025. And I would like to invite Louise Knight, Senior Public Health Intelligence and Research Specialist, to introduce the report, please.
Thank you, Councillor. So I'm Nikki Lang, I'm the Interim Director of Public Health, and I'm here with Louise Knight, who's one of our senior analysts. So just to preface the report, it's a statutory duty for the Director of Public Health to produce joint strategic needs assessments, and this is a short report to inform the Health and Wellbeing Board about a 3-year programme of work which started in 2023. So really interestingly, the first piece of work was promoting the use of the joint strategic needs assessments. So this is like statistical compendiums of the population. And the new focus, which Louise could talk about, is about co-production. And I would just draw members' attention to section 4, which is really exciting, about work that's already been completed. And then section 4.2, which is even more exciting, which is about what's in progress. But I'll hand over to my colleague, Louise, who does all the hard work.
Thank you very much. Okay, so this paper updates on the progress of our second year of a 3-year rolling programme. Essentially, we're proposing to extend our programme by a year to have more time to deliver on that existing programme. So section 2 of the report describes the JSNA. As you can see on the slide here, the JSNA
is actually a suite of very different products that we produce. So that includes in-depth needs assessments, summary needs assessments, short data briefings, and also, as you can see in the middle there, in that mapping, we have the local insight mapping software that's available for everybody to use. So in terms of our action plan, in section 3 of the report, our action plan talks about 10 different areas that we're trying to strengthen across the JSNA programme. You know, over the last year, we've had really good progress. And one of the main things that I'd like to point out is around governance. Even though we've got a really strong steering group for the JSNA that includes people who are representing across the council and also external representations such as the NHS, Health Watch, Community Works, Sussex Police and 2 universities. We have now, actually this was a request from the board in November last year, extended to include further wider determinants of health, including the transport team within the council and including the Parks and Leisure team as well. In section, I think it's 2.4, there's a list of all the representation within our steering group. So another area that's been a real keen focus this last year, as just mentioned, is promotion, communication and maximising the use of the JSNA. You can see on the slide on the right-hand side here, we had a real highlight this year to produce our health count survey report, and this also included a externally funded health and wellbeing board partnership event that took place that brought together different partners across the city to look how the health counts evidence can support work that's already happening across the city, but also what can be done differently to decrease inequalities and these stark inequalities that we're seeing from the health counts research. So also we've done a lot of work around communications, and we're sort of seeing some of those results already. So in terms of our JSNA webpage, we've seen a massive increase in downloads and also views in our webpage. So it's a really good step towards promotion and then hopefully use of these products. We've also co-designed a JSNA comms plan. So that was co-designed with a subgroup of our steering groups that include the NHS, Community Works, Health Watch, and our comms teams to really look at how we can strengthen communications for the JSNA programme. And this also included redesign around our website to improve how that looks and feels. And part of that development actually included a new name and strapline that's been agreed by our steering group. So I'm just going to read that to you now. So healthy cities, understanding our local communities' needs and strength to improve health and well-being and reduce inequalities. So this strapline will now be included on all of our products and also on the website going forward. Actually, delivering on this communications plan would be very much a focus over the next year. So other areas that we've strengthened in the JSNA programme include the engagement, involvement and co-production of the JSNA. So one of the things we did is bring together residents for a user group. So while we're developing how the website will look and how that strap line sounded, we brought in residents to give us feedback. This is really one of the activities we're doing to try and better engage the public in the JSNA. Also, a really interesting project that we did this year is called Research Ready Communities Project. And we worked with Hangleton and Knoll, Trust for Developing Communities and Health Watch to deliver this project. The aim of the project was to enable local residents to lead on health and wellbeing research that's rooted in lived experience. So this project essentially supported community researchers to develop research questions themselves. They looked at the health counts survey and thought about what questions are most important to themselves and their communities. And then within this project, we supported them to actually analyse the data around the questions that they were interested in, and then they reported back and presented that to the health forums. This is a really interesting project, and actually they're really interested in community cohesion and whether that was associated with mental health, for example, happiness scores across the city. So this was from external funding, so we successfully got some external funding to do this from the Sussex Research Network, Engagement Network, REN. And good news is we've actually got some more money to extend this work this following year. So in terms of the actual JSNA programme delivery in year 2, we've done really well. On the left-hand side here, you can see products that we've published on our website and are available to everybody. One of the main focuses has really been analysing the health counts data and publicising that. There are a number of other products, including the pharmaceutical needs assessment that the board will be familiar with. And then on the right-hand side here, you can see the different products that are in progress. Again, there's a huge number there, but just notably, there's the special educational needs and disabilities, neurodiversity and learning disabilities, in-depth needs assessment we're close to completion on. And towards the bottom there, a couple of in-depth needs assessments, which are pan-Sussex. And then in the middle on that list, you can see there's a number of health counts projects we're still underway. One of them is the area profiles, and actually they're just about to be published, so it was almost by today, so look out for those. And so that's area profiles at ward level and PCN as well. One of the important products there that we're doing, or processes we're doing, is bringing the health count survey data into our local insight mapping software. This is really important because it now allows everyone, stakeholders and residents, to be able to map indicators across the city themselves using this software on our JSNA webpage. Okay, so this is my last slide. This is quite short and sweet. This is the Health and Wellbeing Board. We're actually asking you today to note the progress of the programme in the second year, but also to approve this updated programme where we want to extend by an additional year to complete our existing topics and population products that we have on our plan. This actually means that in addition to this additional year that we need, also that we would do the prioritisation process of the JSNA the following year, so that's July 2026 to July 2027. This would probably work really well because it's going to link in with the Joint Health and Wellbeing Strategy update in terms of timing, so we think that would be really sort of important to lead in to that. Okay, so in the Appendix 1 in the report that you have has a full list of all of the different products that we're working on. So you can look at any details there, and otherwise I can take any questions.
Thank you. I'm sorry, my voice keeps going and coming back, sorry. Thank you for the report, and any questions, comments? Yes. Councillor.
Just a little question. Where is it? The research project, the communities research project that happened. That sounds brilliant. And you said that there's more funding to do this next year. Is that with the same community, or will you be looking at a different community in the city?
So we're working with Angleton and Knoll and Trust for Developing Communities at how we're going to use that. That is a small amount of funding, but we managed to do a lot with the last bit. So we'll be working with the health forums again and extending that work with the health counts data and working with communities on that. But very much led by the health forums and what the community wants us to do around interpretation and understanding of that data and questions that are interesting to them. Yeah.
Okay, thank you. Any more questions or comments? Yes, Tanya.
Thank you, Louise and Nikki, for the report. I think it's really, really important to remind ourselves of all the work, as you said, the sort of items and products through the JSNA reviews. I suppose I'm thinking, only because I believe we're now putting together an overarching review of health inequalities in the city and how important it is all of this work that feeds into that. And particularly I'm thinking of our most deprived areas, because we now have the health counts data for each ICT or integrated community team areas and in neighbourhoods across the city. And I'm wondering just how we tie in some of this work and activity and products into the overarching picture on health inequalities, because obviously when we saw the health counts data, it identified we're actually not narrowing the gap, and in some areas they're widening. And I just wondered whether or not you feel this core work and the annual report will support or report on health inequalities.
Thanks, Tanya. It's an interesting question, and I think the focus goes back to what Councillor Bogot said at the beginning about focusing on the wider determinants of health, the Health and Wellbeing Board Development Away Day, so looking at employment and skills and housing as key determinants of health. So without preempting ourselves, we've had some internal meetings with you as well, Tanya. So what we're thinking of, depending on what Chair and other members think, is about doing a neighbourhood level data cut for those wider determinants to, as you say, look very carefully at where people are in more deprived housing, low skills, low jobs, and then where we can focus our work.
And just to carry on, Chair, the reason I ask that is because it's very important for us as commissioners when we think of strategic commissioning for the future. So as we have the left shift from some of the transformation monies into the community, this work is going to be so critical for us to target some of that. So I'm just wanting to tie all those pieces together. Thank you.
Yeah, thank you. I do agree with what Tanya asked. I think that was a good question. But I was just wondering whether the data you're talking about is not already available, because I think we do have a general idea of the most, deprived areas where there's no low, people who are not working and that sort of thing. So I wonder whether the data which you're looking for is not there out there already.
You're right, Councillor Bogot, it exists, and I think in most councils it's cut by ward, so there tend to be ward profiles, but what I'm guessing that ICB and NHS colleagues will be interested in is by neighbourhood. I know things change a lot. It used to be primary care network and now neighbourhood, but we're happy to cut the data in any way that's useful for Tanya Brown-Griffiths or NHS partners. But you're right, we know where the deprived areas are. Just in the council, we're used to looking at wards, whereas actually just for the NHS and its movement, integrated neighbourhood teams might be more useful, so slightly bigger areas.
Thank you, Chair. And I think I would just want to add to that, it's not data for data's sake here. We need to then implement some metrics that we can see improvement. So we know that these areas are deprived areas. So once we've done that, it's then what metrics, because as Tanya quite rightly said, with strategic commissioning and commissioning for the future, we do need to target for those areas that have greatest need. So it's working out what we will then measure to see that we are making a difference. So, thank you.
Yeah.
Thank you. Yes, and you're right. And I think with wider determinants like housing and jobs, the metrics are actually quite, easier sometimes because, it's unemployment, young people not in education and training, availability of safe and secure housing, people not in temporary accommodation and not rough sleeping. So the metrics are probably easier to draw up, and we'd be happy to draw up a list for your perusal, if that's all right.
But if I come back, I think it's not us necessarily doing it, it's the neighbourhoods doing this, because the whole idea of having data that's relevant to the neighbours, they will be very different to other neighbourhoods. So if we are really going to take this through to making a difference and getting the community to make a difference, we can't standardise that at all, can we? We need to sort of put it in the hands. And for us, sort of transferring care and resources, we need to see that things are changing. But that might be very different if you pick one part of the patch to another. So.
Yeah. Thank you for your question. That was also a very good question, and thank you for your answers. Any more questions? Yes, please.
Thank you, Chair. Not so much a question, but just want to put something on the table for all board members to keep in mind, really, which is that whilst we're seeing a lot of real positive steps in the delivery of preventative services at a neighbourhood level, certainly, we're also seeing from a governance level our NHS colleagues moving to a much larger patch with the merger with Surrey Heartlands. And I'm just mindful that forums such as the Health and Wellbeing Board here keep a focus on place-based, citywide communities of interest. I mean, my day job is working with unpaid carers, for example, but we've got innumerable other communities within the city that we want to make sure that we're engaging with on a city-wide scale, just to ensure that their views are captured, as well as those important projects that are happening at a micro neighbourhood level. So I wanted to add that.
Yes, more questions? Yes, do I have somebody on the screen? Yes?
Hiya, I think.
Yes, please.
I think that's me, Jenny Priest from Sussex. I wanted to pick up on Tanya's point, but firstly, just to say, so University Hospital Sussex, which obviously our patch sits across Brighton and Hove, West Sussex and parts of East Sussex. We published our strategy in October, and we were able to make really good use of the JNSNA data, with massive thanks to teams at Brighton and Hove and in West Sussex. So I just wanted to acknowledge that we very much use this data in informing our strategy. And secondly, to pick up the point about the real value of being able to look at the city through those lenses which are developing as integrated neighbourhood teams. So one of the things that the integrated neighbourhood teams will be asked by the ICB and I guess all of us to do next year is to reduce the number of avoidable admissions that generally come in through our emergency departments. And when we look at the data that is available in Brighton, and there's a really helpful dashboard which has been created by the ICB, but drawing data from a range of different sources. You know, we see a massive difference in the avoidable admissions that are coming into our hospital in Brighton from the east than we do in the centre. And those are the kinds of really real outcomes and things that we have the opportunity to change if we're using data really well and working in partnership to change things for people, because we understand more about what's going on there. So I just wanted to fly the flag for the importance of that work, and particularly actually the relationship between the Brighton and Hove team and the work that's feeding into the integrated care teams.
Thank you. Any more comments or questions? Thank you very much. I do know some of the work you did, I think, with the multicultural women in Hangleton and Knoll, and I think it was great work. I just wondered whether you have a list of items or plans you have for the next year with funding, because I think you did a lot on some questions on health issues, and I don't know if you have anything left to do on that.
There's always, you're right, Councillor Bagot, there's always lots more to do. I think just a couple of areas which were on that right-hand side were tuberculosis, so taking a fresh look at tuberculosis in the city, Gypsy Roma traveller needs assessment, and also the special educational needs work. But we're very open to, dynamic needs. So if there's a need for a statistical report on something that's fresh and a short request, then we're always happy to look at it, because we like to move quickly.
I'll just add to that. Also, at the appendix 1 of the report, we have a list of the full programme for the next 2 years that we're proposing. So on top of the SEND, LD, ND, so learning disabilities, neurodiversity in children, we want to then look at adults, and then we want to look at perhaps the transition between children and adults, if that's still required after those 2 needs assessments. So we've got a kind of programme of work that we're working towards in that Appendix 1, which is already pretty full. But again, if there's higher priorities that come up, then we need to address that and make sure that it's included in the programme.
Right. Just a question on tuberculosis. Are you just doing it on particular groups of people or in general? Because my understanding is the cases of tuberculosis generally is increasing in the country. So are you doing it just for particular groups or as a general thing?
It's a general piece of work, and it's for West and East Sussex as well. Thanks, Councillor Booker.
Thank you. Any more comments? Any more questions? So the report recommendation are that the board does the board agree to note the report and to approve the updated proposed program of needs assessment? Agreed. Okay, thank you. Thank you very much. Item number 32, shared delivery plan, progress report. I would like to invite Chair Walker to present the report, please.
Hi everybody, I'm Chas Walker. I'm the Joint Programme Director for the Supports Our Health and Care Partnership, and I'm going to be joined by a few colleagues to support the presentation of our Shared Delivery Plan report. So Steve and Tanya, who are SROs, are going to support where a couple of the objectives where we want to provide a bit more detail where we're not on track, and then we wanted to bring the report to life a bit with a bit of a focus on the work we're doing around our shared delivery plan objectives, around our sort of health inequalities and prevention work. So I'm going to be joined by Joe and Adam and Tori on the screen, who are leading some of our ICT work in that area. So we just wanted to bring that to life today within the presenting the report. So just bear with me, I'm just going to share my screen. Again.
We're offering an open access drop-in style support for patients, and there's a range of healthcare services that you wouldn't see at your GP practice, and often you'd be waiting a long time via referral route to get into.
I think we see a lot of people who are not really sure what they need, but might be kind of struggling and feeling that life is overall a bit difficult. Often people will go to their GP with that kind of worry, but it isn't really actually a kind of GP thing. And the Health Hub means that people can just come straight to us. It's informal, it's a drop-in, it's local.
The main aim of the Health Hub is to provide open access to healthcare professionals for people that might not go to their GP practice, or might feel nervous or anxious, or might just find it too difficult to get a GP appointment.
I needed my ears checking, so they are duly checked, so I'm reassured. I'm quite phobic of hospital environment because of some adverse experiences. So for me, it's actually really important. I am autistic and I have post-traumatic stress. So being in a more neutral environment means that I can access it much more easily.
9 times out of 10, it's just about reassuring patients, or we signpost them on to other services, but that's very rare.
By bringing our services to the local community and embedding our services in the local community, I'd like to think that we are breaking down those barriers to healthcare, you know, whether it's a waiting list or travelling or not knowing where to go. By just having that sort of real local offer is really important, and this is a particularly important place for that to happen.
We know historically that patients living in the Whitehawk, their life expectancy is up to 20 years lower than people living in Hove, which is 5 minutes away. You have to get people much earlier because you don't have as much time to make a difference. Basically, it costs the NHS nothing to save itself tens of thousands of pounds later, especially if that patient doesn't engage.
Well, I come down about my hearing aid because I'd never used it. I'd had it since November, and I wasn't quite sure how to use it. Everyone was so helpful here. It was everything. I've got a doctor's appointment next week with my leg because it keeps giving out, and they were extremely helpful. I've only been here about an hour, and I've had all that service done. You know, it's been great.
Our reception team is amazing, and they do such a good job of talking to people, figuring out everything that's going on, and then helping them identify what practitioner they might be able to see that day. And it can be up to 4 people. So they might think that they're coming in for one thing and then actually see other people as well.
So someone might come in with shoulder pain and specifically want to see a physio. Whilst they're speaking to the physio, it comes out that actually, you know, their benefits have been stopped for a number of weeks, and as a consequence, they haven't been able to get the bus to go and see their family. What they can then do is see perhaps the welfare benefits advisor or a social prescriber who will be able to kind of look into this with them, you know, offer them that support.
Well, I've come for get a COVID. I'd rather speak to someone face to face, you know, all that ring here, ring there, not into it. You can just pop in, book in, you know, so this is brilliant.
I think this is one of the best ideas that the area has had. They come down, they have the coffee, they see who they want to see, then might have another coffee, and then they go off. They've had contact. There's so many people, and there's so many people talk about it now. So it's a blooming good.
This is a fantastic service, and it's in exactly the right place, which is a location that they know, which they can easily access, which doesn't cost money to get to, and which is stable and always here. Is fantastic.
So we've had so far over 400 people come to the hub, and less than 10% of those people have received a referral back into the PCN team for extended support, which is really great, because what that tells us is kind of capturing the need when they come to visit the hub, rather than being added again, you know, to a wait list to be seen by a team. And that's not to say that we can't offer that extended support. But the idea of this is to really kind of provide some answers, some clarity and some reassurance when people need it.
We brought health professionals right into the heart of the community. This is a safe space for the community, so people are able to come here and talk more in a more relaxed, open way about the health issues that are really affecting them.
Quite a lot of people come here and see our mental health support coordinator and see a social prescriber and see a nurse, and perhaps a little bit of all of those different issues is all getting looked at the same time. Might help people to cope a bit better with those kinds of combined challenges when there's lots of different things going on at the same time.
Okay, so thanks for everyone watching that. My name is Adam Fazakali and I'm the Clinical Director of East and Central Brighton Primary Care Network, who set this up. So this all started 4 years ago as an idea based on Rebecca Morby's work, and the idea was that staff spend a lot of time managing the admin associated with complex systems, and this takes time away from patient care and contributes to burnout. In addition, we recognise that there's no one coming to save our local health and social care system. It's us in this room, it's the collaboration between our organisations and communities, and this is where we'll find the solutions, and time is pressing. So this led our PCN to design this drop-in health hub, where anyone, but especially under-resourced individuals, can drop in. And there was no sort of bureaucracy, there was no silos, there were no referrals, so it was pure just time spent caring for patients, which is extremely rare in our system. We also knew this would fit with the neighbourhood agenda and would give local partners something to work towards. And it's taken time, but we've developed relationships with a broad range of partners. Hopefully this cues the broad range of partners to come up. But I'd especially like to highlight the hospital. So they approached us directly and said, we want to work with you, and they're offering a respiratory consultant to come to our hub and lots of support in joining up care, because we separate care from GPs, but they're so connected, and the more we can sort of improve that connection, the better things will be. So with regards to ICTs, it's not the end, but it might just be the end of the beginning. So to sustain this way of working, we need ground up shared goals. We need to do more of what works, less of what's not working. And in order to focus on prevention, we must understand the causes of ill health and ensure funding follows integration and ensure there's support for innovation at this sort of level. I'd also really like to thank the 9 GP practices of our PCN who personally funded this out of their budget. And this was their commitment to system goals, social inequality, and how to improve care for our local population. And that is quite rare in the system, so I think they just should be commended for that. It also would not have been possible without our ICT leaders, Joe and Una, who are on there. And if anyone would like to work with us, please contact. And if they'd like to visit the hub, I'm happy to facilitate that as well. And if you just look, the core of ICTs is about joining up various organisations to work together for a goal. And this has taken a few years, but it's quite an impressive list already. So long may it continue. Any questions?
All right, thank you for your report. Any questions, any comments?
Sorry, we've got one more bit.
One more? Oh my God.
Sorry, Charles, you need your mic on.
Yeah.
Yeah, so we just heard from an example of the work that they're doing through the East Brighton ICT. We're now going to hear from the West in terms of from Joe and Tori, who are just going to present a little bit of work they're doing around community health and care. So,
thank you, Chaz. My name's Joanna Martindale, and I'm the Chief Executive of the Hangleton Knoll Project. And one of my roles is to facilitate the West Brighton and Hove ICT Leadership Group. I'm going to go over to Tori so she can introduce, because it's harder when you're online, I think, to talk a little bit about the partnership of our community events programme. Tori, are you there?
I am. Can you hear me?
Yes, all good.
Yeah. Okay. I'm Tori Lawrence. I'm the operational manager for the Primary Care Network, and work very closely with Joe and the West Area ICT. So the West Hove Primary Care Network's been collaboratively working with the Hangleton Knoll project on proactive preventative health events and projects targeting patients of the West Hove population for the last 6 years. This work is built on the insight from our local community, where I sit as an active member of the Community Health Panel, who steer the topics of the collaborative wellbeing events. I also sit as a member of the steering group for the planning of the events we collaboratively deliver. And in addition, Joe sits as a member of our PCN board and is also our PCN inequalities lead. So basically, it's the trusted relationship that's enabled the PCN and Hangleton Knoll project to build on the success of the collaborative wellbeing events we've delivered and deliver and develop healthcare pathways together for the highest ongoing needs, the frailty test and learn, diabetes, cancer, and many other health conditions. It also helps that primary care and the voluntary sector are very similar in the way that they're agile, flexible, know their local populations, and can make decisions enabling action and successful outcomes to be delivered. From the voice of our clinical director, Dr. Rowan Brown, sums up our collaboratively wellbeing events perfectly, stating, events like Well in the West, hosted and organised by the Hangleton Knoll project, engage patients who would otherwise be missed by traditional healthcare services. This is key in triggering change within the community, reducing our local health inequalities, and demonstrates the power of collaboration with primary care and the voluntary sector. Okay, over to you, Jo.
Thanks, Tori. And I think that's a really important overview, because the entire point of bringing health into the community is it's a partnership. And we have a huge range of partners that are happy to participate and come and be part of the health events. Being Well in the West started, we've had 3 so far, is the big main event and very much targets in a whole community way the council estates of Hangleton, Knoll, Portslade and Mile Oak. And working together with the PCN, we aim to give a really holistic offer. This event that you're seeing showcased here was sponsored by the MSK service. And that meant that we had physios in the room, we had pharmacy teams doing BPs, we had a point of care health testing, looking at blood sugars, and you can see that they're extremely busy, popular events. Over 150 people came to this, and what's lovely to see, you've got real social prescribers in the room, Age UK, Together Co, linked to the practices, but you've actually got actual social prescribing happening in the room, where people who are talking to the bowel screening team might say something and they are able to be walked across the room and seen at the same time. So it's extremely holistic, and underpinning all the events is a digital health offer too, as we aim to help people get on NHS app if they have a smartphone, and work through health advice and information online as well. So you've got everything going on there. In our communities, there's a lot of digital exclusion, and it's really important that we do a lot by flyers and by word of mouth. But where people have got a smartphone, but maybe not got the confidence to download an app, that can really work. You can see, when we went past, there was a quote from Dr. Rowan about engaging patients who don't otherwise get involved in healthcare. And I think that some of the results are really interesting. We always pick up very high percentage of people with high blood pressure and give advice about buying a monitor or testing again. And I don't think we've ever done an event where we haven't found at least 4 or 5 unknown diabetics. And that's the sort of being able to be very proactive in that way, and at the same time as picking that up, have a bit of a chat and talk about some free community exercise programs, health. It's a nice blend. Okay, next slide. This was an event we did that was very specifically targeted around mental health and well-being. I should say that really it's all the same cohort of people, and many people living with chronic conditions in a more deprived part of the city also experience mental health issues. Whether you're waiting for healthcare or whatever's going on for you in terms of cost of living, we do know that mental health is one of the highest needs in the community. So we did a very specific event that targeted that. The UOK partnership is a partnership of about 15 voluntary organisations, of which the Hangleton and Knoll Project is one. It's led by Southdown. And it really gives some very specific support, help and advice wrapping around other services. Marlow, if anyone, I mean, Pfizer knows, Councillor Baghoff knows exactly where it is. Most people local to Brighton do, but some people in the room aren't local to Brighton. It really is right at the fringe of the city, and people there do feel quite, well, anything in the town centre is a very long way for them to go. So we took Healthy Heart right out to Marlow Medical Centre. And you can see again some really interesting testing was done, picking up people who, out of those 94, 7 with diabetes, but also we were lucky enough to get the FibroScan in too. And these tests really also supporting conversations about what people might want to do to reduce their risks. And that's the whole point of the community approach. It's non-threatening, it's non-judgmental, and it's all just part of a conversation. And very much, as in the East Health Hub, you don't have to pay to get there. It's kind of easy. The final slide, and I'm galloping through a bit because I realise it's a long evening, but this supports some of the Women's Health Hub work, and it was a very targeted event at the Hangleton Estate, which is another council estate that's very much at the fringe of the city. And this is where, if you do this work, you really do find a set of people that don't necessarily access traditional health care. It was quite stark that 10% of the 39 who attended did end up with an urgent cancer referral because they hadn't taken their breast lumps anywhere else. And I think it's a hard thing for the health system to hear because we know how pressed everybody is, but there is huge amounts of unmet need. And that is what drives our health inequality in the city. And this is in some way of addressing that. We've been able to work with Dr. Zoe through the extended kind of creative use of the extended hours service to continue to do menopause support quarterly in the community. And that's something we're very grateful for our partners in Brighton Hove Federation for supporting. Final slide is a kind of a what else, and we've got a lot going on. There's been a really nice project, a partnership between Hangleton and Knoll Project West Hove PCN, specifically Portslade surgery, led by the HERE MSK service and evaluated by the King's Fund. And this is really trying to take some of the work that we've done in bringing health into the community, looking at it in a holistic way, and think what more could be done in terms of getting upstream of some of the MSK issues. We know that a huge percentage of our GP appointment requests are around MSK. I think from memory, it was more than 70 appointments a week are requested at Portslade for MSK. So the idea is that we've set up a pathway into a weekly drop-in, as well as advertising the community, and give a very holistic look for those people. We know, again, that from the data that people experiencing MSK issues are also likely to have problems with diabetes, mental health, and cardiovascular disease. So being able to address all those things in one weekly drop-in has been really helpful. And we've got a range of community volunteers that are supporting those drop-ins alongside our colleagues who work in social prescribing, etc. So we're testing that approach at the moment, and the evaluation of that will be in 6 months, and we'll tweak again and see how we go. I won't read through everything you can all read on the slide, but perhaps it's good to highlight the partnership work with the Recovery College at Southdown, really showing that in the West that we don't separate mental and physical health, that we really look together in a place-based way at what the gaps are, identified either through community insight and data, and then in an agile community development way put on an offer that enables those needs to be met. Perhaps I'll leave it there, and I think we really are finished this time. Thank you, Chair.
Okay. Thank you for your reports, Matilda and Charles, and all the reports. Do you have any questions or comments? Yes, Councillor Halliwell. Yes.
Thank you for that overview on some fantastic work, and I do know Marlow very well because I live in Portslade and I am councillor for North Portslade, and Marlow Medical Centre is my surgery. So yeah, I'm very aware of that area. But I was just reflecting on the difference between the two approaches there, and I think possibly one of the real benefits that Adam is that his hub is in the same place, so people can access it all the time, whereas this seems to be sort of like a moving target. Are there plans to sort of collaborate with the local surgeries and to get a more sort of locally based hub, or what's the plan there?
I suppose to make these was like tests of change that East ICT ran. So one of the things we've talked across the 3 ICTs is that we actually want to, I think in the next few months, bring an event together with each of the ICTs to look at the learning around these different sort of community health models, and then from that learning start to think long term around, because hopefully you can all see this is that left shift, is it? This is that sort of integrated working that the NHS long-term sort of plan is talking about. But I think we want to use the learning and then think about what those long-term models, and whether that is static hubs or whether these are what, you know, the difference between the static hubs and the different events. So
it's an interesting point. We had to work with the assets that we had in each area. East attracted quite a large sum of money to put on those weekly health hubs. There are staff also employed not within the surgeries but outside the surgeries, so there are staff run that. So the location of their hub is in Whitehawk. What we've done with the health events is do a kind of a shoestring model in and move the events around so they're actually also within the hearts of their communities, because Milo doesn't always want to travel to Knoll. It's not always that easy. So there really are pros and cons, and I think we are trialling a weekly hub with the MSK in one location, and we'll see how that compares. In terms of numbers of people seen, it works out quite similar. So there are different comparison points and different ways of looking at impact. And I think I just want to underline what Chaz is saying. I don't think there's a right or wrong model yet for the city. I think there's a locally tailored set of models emerging that fit with the assets that each community have and start to understand the needs of those communities better. Adam, I know you were hoping to come in.
I was just to say that in the 10-year plan, the idea is to have these neighbourhood health hubs, a bit like the one we've got, but hopefully much better with their own estates. And there's no talk of how they're going to do that or what money's available, but it is definitely our vision as a federation to use any profit we make to invest in estates and work and have a hub in the east, the centre and the west, because it's only going to work if we can do this across the city, but it requires a huge amount of resource to do that, and not something any of us have right now. But in the future, when these contracts come out, I think we can dream that, none of these models are the finished article, but we can dream that patients know where to go to get help, and it's really easy for them to do that. And especially it's help that's not medical, if it's, mental health related, social related, they can go there and get sorted. So that's the dream, but we're way away still.
There's something about changing the culture of health also from the bottom up, and starting those relationships within each ICT area, as Tori discussed. We really work very closely as general practice, as community, alongside pharmacy colleagues, other VCS, and sometimes you really build those relationships by working together, and I guess that's another thing that we're trying to do.
And sorry, if I can just and also, what is your strategy in letting people know about these events? Because obviously it seems that you've got great attendance, but how do you know you're hitting the most amount of people?
Yeah, we are at capacity at all our events, really. What's interesting is that we work together with general practice, so there's a targeting of their patient list via text message, and then we do the full community network bit. That's social media, flyers, posters, word of mouth, outreach to groups. And what we find, and I think it's really interesting, is that between everything, it works out about 50% come through the GP route and 50% through that whole variety of community route. When you look at things like ethnic diversity, that tends to come through the community route. If you look at some of conditions, that tends to come through the GP route. So there hasn't been the analysis on that, and I don't think we've done enough yet. But that's something that we also we're working across all ICT areas to really understand.
Thank you, Councillor Halliwell, for your question. That is a very good question, and thank you for your answers. But just before I give it to you, I had the same thinking query, which is about continuity, because we know health is something which is, it's something which happens every day. So when we talk about events, and I understand from the report that an event can take about 6 months. So maybe that is about 2 events in 1 year, while people are having, issues which they might want to be advised about. That's one thing. Another thing about the moving locations. We know that Hangleton and Knoll is one of the areas which has a lot of elderly people, most deprived, with multiple morbidity. So they need accessibility, something which is quite near them. So when it's moved to Mylock, probably most of the people who would need to go to these people wouldn't go. My other issue is, of course, I have worked with Hangleton and Knoll project, and I know the great work which Hangleton and Knoll project does. A lot of work, like health forums and cancer and everything. My worry is that we have to find a balance about what we give to community and what we take it ourselves, and not only, and especially now that the funding are much less, by focusing our funds in something which will bring more rapid and evident results in the health and well-being of the community, rather than in more things, just ideas or pilots. That's my opinion. And I think the community is very good at well-being activities. But I'm afraid that we might be giving them a load which is more than what they can handle, because I believe that things like blood pressure, blood sugar, these are quite serious diseases, and I think professionalism, medical professionalism is very important, because I think it's known that just one reading or once in a while, it's not something which you can take for granted that that person is sick. And also the culture, I'm also aware that this can lead people to sort of ignore, as they get used to coming to events to be picked up. They ignore the fact that they have a duty to themselves to go to doctors. Another factor is about fear of duplication, which we are trying to avoid in duplication, because this blood pressure and sugar tests, these are things which are done yearly for most elderly patients when they go to their GP. So, I mean, it's about finding the balance, who does what, and not overloading one or putting something where the specialty isn't enough to give us the results we need. So, and that's my taking, or whatever you call it. Yeah. I don't know if you have any reply to some of the
Just a clarification, Councillor Bagos, Hangleton Knoll Project aren't doing the blood pressure and point of care testing. That is all held under the standard operating procedures of the partners that are attending. And very much, this is an empowerment piece. It's very much about talking with people about the importance of blood pressure testing, whether they can go in their community and pharmacy to get it done, perhaps considering buying a machine. So I would say across the city, a very big part of all the test of change models is that community education, but starting where people are at, rather than assuming that they have any prior knowledge.
I was just going to come back on the first point you made around the sort of numbers of events you can run and how and the level of reach that has. I suppose just the important point to make is that currently all partners have been doing these across all of our ICTs from existing resources. Now, obviously, I think we've all now sort of seen the new NHS Sussex transformation sort of written out the commissioning intentions, which talk about that 3% over time shift from the acute into the community. So I suppose as ICTs, we're hopeful that as that money starts to shift, that these sorts of initiatives might be able to then pick up some of that additional resource, and we can build that capacity, because this is all about that early health prevention and tackling those areas with their particular health inequality. So we're hopeful in time that we'll be able to increase the capacity. But I think the key thing is we run these as test of change pilots. one of the most important elements of them wasn't just the delivery to the individual recipients, beneficiaries of those health interventions. It was actually getting the partners to work together to design these models and to really get confidence and build trust in working together. So I think one of the things we really want to do in the next 6 months is really look at what we've learned as ICTs through these, and then think about how does that learning then inform that left shift, that long-term sort of neighbourhood health approach into our communities. So, and I think some of the points you made, Councillor Bagoff, were really helpful in terms of things that we want to be discussing when we come together and think about the learning. So,
just one addition. Do you have any percentage of the population, the total population who attend those events? What percentage of the total population of the area attend those events, please? Do you have that data?
We don't have that data to hand, Councillor Bagoff. We can obviously, I think, once we're pulling it all together, I think, and running that's the sort of thing we might well look at. So, but again, I think we were limited by the resources, the existing resources. So I think that was a key factor. But we were certainly, as we analyse the learning, we'll look at the percentage reach, maybe especially percentage reach into particular areas and wards where we have higher levels of deprivation. So,
thank you. Any more questions? Yes, please.
I just want to thank everyone for the presentation. I found it really inspiring, and I shall be contacting you, Joe, to get myself an invite to the next one, if that's okay. And also, so is it, Adam, shall I contact you for an invite to White Hawk? Thank you. I have a couple of questions. First of all, the Women's Hub. Did that move around, or was that sort of in one place, and whereabouts was it, or is it?
So that was within the GP surgery, and I think we started it, and all that was highlighted was that the demand was so great, and the money was, really, really small. It was, I think, 10 or 20,000 pounds to deliver it. So, women's health is huge. It's 50% of our population. So it's we're looking at how do we make that financially sustainable to do something that's actually going to work long term. And I think the way to do that is to work with, the Knoll Project, work with Trust for Developing Communities, and we provide the clinical staff and they help with the reach. But we've got a long way to go until we work out how we're going to fund it, basically.
Yes, please.
Oh.
And then regarding the Women's Hub again, on one of the slides it said that the number of appointments was much lower in Brighton and Hove than in other parts of Sussex. Was that to do with a smaller geographical area, or was it to do with just less sort of funding for it?
Well, the answer to that, I would have to, very long answer. I'll try and shorten the answer, but I think in Horsham, Horsham got the same amount of funding as Brighton, and it's obviously much smaller. And the complexities of doing anything in Brighton are different because we've got 31 GP practices to try and work together. And the way the funding model works is you can do the Women's Health Hub if you go to the GP practice and get income from doing work that the GP practice hasn't got time to do. Now that is very, very complex to do across 31 practices, and we're just working out how to, when we've got some practices not doing any of it, some practices doing lots of it, we have to work out how to do that equitably and fairly. So it's really just a logistical problem that we're trying to solve. Yeah.
Thank you.
Yes, please.
I have to try and remember what my other things were. Question for Steve. You mentioned the new transition person. Are they, I think you said next year, is that sort of early in the next year that they're going to be starting work?
Thanks, Councillor Alexander. Yes, in terms of the programme manager, I guess notwithstanding the Council's recruitment controls, we are starting recruitment early in the new year, so we hope to have that person in place kind of by the end of March, beginning of April.
Okay, thank you. Any more questions or answers? Or comments, sorry. Yeah. Yes, please.
Thank you, Chair. Sorry, Monica, you go. You had your hand up.
Yes. Sorry about that. Yeah.
Thanks. I guess whilst the health hubs are providing a platform for voluntary sector partners to perhaps meet commission KPIs that they might have in various contracts, which is a really valuable opportunity for us, there certainly is, I'm sure you'll all agree, an element of the sector giving it that extra bit of effort to try to make these partnership events work and sort of coming together in ways that they might not have done themselves if they were leading on the events. So I guess an invitation really to Joe to speak to the flexibility and the adaptability of our sector and how that's helped to make your events such a success. And similarly to Adam with the impressive list of partners that you illustrated there, we've been very happy as the Carer Centre to participate on both sides of the city.
Yes, as Tom says, Carer Centre has been present at several of our events, and I think that what has been quite special about the putting together of ICTs is the beginning of a change of culture where people are looking at how they can come together in a more holistic way and meet the needs of local populations. And it's correct that there hasn't been additional money for this activity to take place, and I think it is of great credit to organisations like the Carer Centre who haven't got huge resources but are willing. I mean, the Knoll has, I believe, the highest density of carers in the city, older people carers. So to come out to meet people where they're at, to have those conversations, I just think is a really powerful thing. And everyone here knows that I believe that the community and voluntary sector can have that reach, that specialism, and that can really add value to the health and social care sector in this city. Tori mentioned earlier about the ability of primary care partners and community and voluntary sector to come together around those needs, make quick decisions and do things. To me, that is the absolute heart and spirit of what we hope to bring to neighbourhood health going forward. Thanks, Tom.
Thank you. And yes, please.
Thank you, Councillor. Look, first of all, I just want to say to all of you that have been in that presentation, and I would say Joe and Tori, Adam, it's not just the people we've seen there, it's the staff we've seen actually looking like they're enjoying their work. I mean, I just think we have to embrace that for a start. So it looked like to me a really fantastic example. But let's be serious what this is about. You know, we've talked about Darzi 3 shifts, and Darzi 3 shifts are not just 3 things we need to do. This is actually trying to stop people to go into hospital and to save money in the health care system, to redistribute that out into the community. And as NHS Sussex Neighbourhood Health Framework sets ambitious targets to reduce the number of people going into hospital both this year and next year, 3% and 5%. We have to then move that money back around the system. And it's up to all of us, whatever part of the system we are, to commit to this. We see it working. And I don't care whether it's a distributed model, whether it's a building. You know, this is about people getting their health care. And actually, people may not go to a building council because they just don't want to go to an event where it's seen as healthcare. They may want to access it more in the way that you're talking about. So we have to operate different models. So I think you should all be really proud of what you've achieved with very little resource. Now, we are coming together as the 2 ICBs. And one of the things I asked straight away with the 2 new ICBs is to say, Surrey and Sussex need to come together and learn from each other what we're doing about neighbourhood, place, different models. So we are planning to start to think about what can we learn across the piece. But we can see This isn't Churchillian. We don't just push people into, you're in an ICT here and this is how you work, because we've already seen in where you are, Knoll, Marlow, they're different communities. So we have to go where the people are. We have to bring the voluntary sector in with us. We need to bring the services provided by the local council together. And we all have to commit to this, because this has been done on a shoestring, and I commend you all for what you've done. But this is the direction of travel. And if we don't commit to this as a board going forward, then we've lost these gems that we've got here. So I want to thank you all, but I think we all have to continue what we set out to do. And those commission intentions are real. And, taking a shift doesn't sound 1%, but it actually equates to quite a substantial amount of money. And it's fantastic to hear our colleague from the Acute Trust also saying, we want to play as well. We're going to bring out our resource into the community. So thank you all for what you're doing, but every single one of us has to commit to this. And I take that really serious. It's a challenge to all of us on this board. So thank you.
Thank you. Any more questions? Yes, please.
Just a little one. So, are there plans in the future to take sort of this model out to sort of other areas in the city? I'm a councillor covering Coldine and Stanmer ward, which also includes Moulscombe. And although we've had some sort of, I run a food project in Moulscombe, and like today we had someone from PCN coming to the food project to speak to people. But I would love to see sort of like a bigger event in Moulscombe. I think it would be really beneficial to some of the residents around there.
Thank you for your question, Councillor Alexander. I've been wanting to get, because it makes it sound like there's only community health going on in the 2 ICTs, and we were aware of time, so we thought we couldn't really add a third one in. But our central ICT are doing very similar sort of programs of work. They're using, again, slightly different. They're bringing health into existing community hubs. So the old boat's a really good example, sort of thing, where actually, they just had the SCFT community frailty team went in and did a session with that community. So that work's also going on in that ICT as well. It's just that there was limited time to today, sort of thing. So yeah.
Okay. Yes, please, Tanya. Do you have any question or comments?
No, comments, because I think it's of no. Thank you, Chaz, for raising that, because I was just going to say this is just a taste of the myriad of programs that are being delivered through the Neighbourhood Health Programme as we fully roll that out. I think Chaz mentioned the highest on ongoing needs, MDT, so we have a number of MDTs across the city, also looking at those persons who we know would benefit more from a sort of care coordinated, anticipatory planning, and very careful coordination of their care so they don't fall between the gaps. And I think of note for our shared delivery plan and why we wanted to showcase, 2 areas, and we could have done, all 3 areas and showcased more of some of the work we're doing, is because these 2 models, and, as Monica said, there's no one fit all. And that is what we're moving away from, traditional healthcare where people go into a hospital or go into the GP practice, and taking that into the community. And I just want to clarify, by community, we do not just mean voluntary and, sort of community sector or patients, people in the community. We mean community health services, community and local authority, adult social care services, housing. Those are community services, and that's what we wrap around all of these neighbourhoods. So we're not changing in terms of skill set and wanting persons who are perhaps not trained to deliver some of the healthcare interventions. We're bringing healthcare professionals into those hubs and into those roving and drop-in centres. So I just want to clarify that this has been carefully and keeping in mind that we want to ensure we safeguard people in their professions as well as to the communities in terms of the people who receive those care.
Just to support that, and we need to decide how to bring the public along, because their cooperation in this is crucial, and how we do that's going forward we need a better strategy than we have now.
Okay, thank you. Any more questions or comments? Going back to what Monica said about learning from each other. We do understand about the Women's Health Hub that it is working in West, and ours didn't work. So is it something that we can learn and do it here? But I also understand that one of the facts you said about hubs is the funding, which is a problem. So how many of these hubs would we need in Brighton? Brighton isn't very big and the population isn't that large. So is there a possibility of having maybe not every PCN having its own hub, women's hub, and having the model which is successful, the specialist, but maybe just a couple as an option?
Absolutely. I think, like I said, we sort of just finished the beginning stage, and now we're going to we need to wait from what happens from NHSE, because they are saying there will be neighbourhood level contracts. They'll be saying there'll be Brighton and Hove size contracts where we can either have a physical building or we can run 6 different, sort of hubs in different communities, but it will totally depend on how those contracts are outlined.
Could it be that one of the reasons that the attendance wasn't very good because it's a hub, because it's women's health is something I think maybe women are not so encouraged to come and discuss their issues in a hub, which is an open space? Could it be one of the things? So
it wasn't. Our attendance was so oversubscribed. So it was the number of appointments we could offer with the clinician. It wasn't. We asked our various population, would you like to come to the Women's Health Hub? And we had to close it after something like 3 weeks because there were so many people who wanted to be seen, but we just didn't have the funding to see them all. So that was the main issue.
Specifically for women's health?
Yeah, it was a long list of things you had to deliver that were all related to women's health, and it got filled up straight away because the need is so great, and that's the challenge we face really. And I don't know if you want to.
Yeah, just wanted to add. So I think we need to perhaps think about taking back a specific topic on women's health. I think it's one of the areas we discussed. It's not giving it the full time it requires, because I could go into details around what the women's health hubs should deliver and the models that are recommended. And this is by diverse engagement with members of the public. So they want to have a hub, they want it in a clinical setting, but also they want to ensure that it has a social community element. So that's what women from all backgrounds, ethnicity, age, and so on have said. And they certainly don't want it to be over-medicalized. And I think that is the really important thing, is that there's mental health, there's NHS checks, there is other things that, women want to discuss that is not just routine healthcare. In each health hub, just looking at the information, so core services include contraception counseling, pest refitting, cervical screening, menopause, menstrual health, preconception, breast pain assessment. But additional services are like blood pressure checks, NHS health checks, mental health screening, domestic violence advice, and we spoke earlier about some of that early identification, smoking advice, annual reviews, family health, and MMR, advice and support. So it's a wide, comprehensive service, and what we have wanted to test, which is, the national guideline, is what models work best. And certainly in terms of the funding has been the same amount across each of all of those hubs. And we now have 5 hubs across the Sussex patch. And yes, Brighton and Hove, for the population size, you can't really compare it to Horsham, and you can't compare it to maybe Worthing. But when you look at Eastbourne, Hastings, and you combine those two, those models are working. And I think some of that, as you mentioned, is do we have enough sites? Because if we just have one site in the city, of course it's going to limit a lot of people from accessing that site. So we need multiple sites. Do we need a model where some of that is also roving across GP practices in different areas, which is a model Adam and the Fed are thinking through. So I think I just wanted to make it clear that there's a lot else happening around that. We also have GPSI, so GP with special interest in women's health, in practices already delivering women's health. So how can we bring that all together in some of the hub work we're doing? Prevention Advise, we have Public Health who commission cervical screening and other aspects of screening program, particularly in terms of sexual contraception services, I believe. So I think there's some public health services that we want to go through the list and see how can we commission these in alignment. And I don't want to speak out of turn. So Nicola, you might want to.
Yeah, thanks, Tanya. So we definitely have an interest. We commission long-acting reversible contraception and are very interested in committing to this model as well. In my previous council, the model was, as Tanya said, per primary care network. But there's a lot that we commission from primary care that could contribute financially as well. So really excited to feed into that. There are neglected specialties, which is around the menopause. It's that whole well woman model, but I'm really happy to continue. Cervical screening is still with NHS England, but we've had these long debates in my previous council as well. Really excited to work with Tanya.
Okay, thank you very much for your report and for all the good work you're doing. Welcome, Noel and Chas. Now, I would like to ask the board, do you agree to note the report? Okay, the next item on the, do you need rest or shall we finish? What do you think? Do you want a break? This is the last item, right? Okay, sorry, I forgot about the break. Better Fund, Assurance Against Better Care Fund Delivery. Okay, I would like to invite Charles again, and Charles, you're already there, Steve Hook and Tanya Brown-Griffith to introduce the report. Please start.
Great, thank you, Councillor Beckhoff. So I'm very aware of time, so this one won't take, I don't think it will take as long as the last item. So I will just share my screen. I've just got a very quick summary of the report that went out with the papers. So this report, we're asking the board to note performance against the Better Care Fund plan for quarters 1 and 2, the first 6 months of the year, to note the sign-off of the Section 75 agreement between the Council and the NHS Sussex as one of the national conditions for the Better Care Fund. Approve, and this is the important part, we need to approve the revisions to the 3 metrics targets in our BCF plan, and there's a little bit of information regarding planning for 26-27. So just in terms of the key points of the report, I can confirm to the board that we met all the national condition requirements for the Better Care Fund grant. I can also confirm that the Council and NHS entered into a Section 75 agreement as required within the national conditions. In terms of our performance against the plan, I can confirm that expenditure at the end of quarter 2 was in line with planned expenditure within the budget. And then in terms of the performance metrics, and this is where we'll just spend a little bit more time, and Steve and Tanya in a minute will talk a little bit more about a couple of the metrics where we're off target. So that we're on the discharge delays, we're off track in terms of the planned target metrics, and emergency admissions, we're off track. Residential admissions, we are on track to meet our planned targets by the end of the year. But just noting there was a small mistake in the report. We used 281 admissions in the report as the planned target, and it's 253. So apologies, I just want to bring that to your attention. So, just in terms of so I'll cover now the revised metrics part, and then Steve and Tanya will talk a bit about the metric targets and give a bit more assurance around how we're trying to meet those. So if board members remember, at the last meeting we confirmed that we only had conditional approval from NHS England for our BCF plan. This was the same for all 3 health and wellbeing partnerships in Sussex. We're only given conditional approval. when we submitted our plan, we submitted based on the trajectory information we had on our metrics, that showed a standstill position on the previous year. NHS England were keen to see a stretch target for those metrics. So they asked us to go back and review those metric targets and submit revised metric targets for quarters 3 and quarters 4. So, as a partnership, we've gone back and we've looked at those metric targets, and can just confirm to the board that what we're proposing is for discharge delays, the existing target is 1.51 days. And then what we're saying is the new target we're proposing is 1.33 average discharge delays. For emergency admissions, the existing target is 492 admissions on average a month. The new target we're proposing is 483 admissions a month. And for the residential admissions metrics, the existing target is 253 admissions, and the new target we're proposing is 248 admissions. We have met with NHS England, and they have confirmed that they would be happy with those revised targets for quarters 3 and quarter 4, but they do need approving by this board, and we need to confirm to NHS England that the board has approved the revision of those metric targets within our BCF plan. So I'm sort of really mindful that that we're talking about not already meeting the metric targets, and we're then saying we need to stretch those metrics targets. So Steve and Tanya are just going to provide the board with a little bit more information around the 2 targets where we're most challenged, the discharge delays and the emergency admissions targets. So I'll just move on to Steve. I think you were going to talk to this one, weren't you? So.
Thank you, Chair. So in terms of our current performance around delayed transfers of care, or in terms of the new terms from acute hospitals, no criteria to reside, Chaz has briefed the board that we've got some challenging targets set around our Better Care Fund performance. However, I guess we are part of an improving picture in Brighton and Hove in terms of our discharge performance. The graph on this current slide shows you that we currently have 17 people who are delayed in hospital at the Royal Sussex County Hospital, and we have 4 cases that are currently unallocated. That's a significantly improving picture towards the picture we had at the start of this year, and certainly at the same point this time last year, when our delays were higher and we had a challenge around allocating around 40 cases, we now only have 4. Because of our challenged position, we are receiving some additional support through the Better Care Fund support programme. They've allocated us a delivery partner called Consortium 24, who are working alongside colleagues in our acute hospital, at the county hospital, colleagues in the Sussex Community Foundation Trust, who deliver our kind of home first pathway through urgent community response, and also for those of us working in adult social care. Alongside that, there's been increased investment in senior therapists in our acute hospital. I note Jenny's had to leave us, but in terms of our wards, we know that the journey out of hospital begins when you're on the acute ward, and it begins with a therapy-led approach around promoting independence and mobilisation. So we have additional therapies on our acute wards. In terms of our Home First team, who do all the work around discharge out of hospital, we've co-located that team in the acute hospital with a thing called the Transfer of Care Hub. And the Transfer of Care Hub is like a receptacle where all of the patients on the wards that are ready for discharge get funneled into that hub, and then we allocate with that hub the best pathway out of the hospital for that person. So we've co-located those services. And in terms of accident and emergency, we've moved towards a 24/7 discharge model out of A&E. So currently we were operating a Monday to Friday service around admission avoidance. We're now moving to 7 days a week. We've also done some work with our acute hospital colleagues implementing things like personal health grants, and a new self-funder service was launched in October at the hospital, which enables people who pay for their own care coming out of hospital to make those arrangements more quickly. We've also, via our Help Force initiative, have got increased use of volunteers in accident and emergency, supporting those people with non-clinical needs to get back home as quickly as possible. We've also got better support for complex needs through our initiative with improved support for carers. We have homeless prevention officers, and we also have mental health recovery workers in those in-reach teams. And as I've said, Consortium 24 is working with us over the next few months on continued improvements. In terms of discharge performance, our team that works out of A&E alongside the acute hospital, called the Admission Prevention Team, has successfully diverted over 4,000 people away from A&E since its inception in June 2023. And around 62% of those have either gone directly home or into short-term recovery services rather than being admitted into the acute hospital. If we could do the next slide, Chaz, please. I'm going to just talk through this. This is around the prevention and urgent community response around admission avoidance. And this model really describes a range of different tools we're employing. We're using a thing called the John Hopkins stratification tool, which is being rolled out around complex and ongoing needs via our integrated community teams. You can see on the right-hand side of the diagram our urgent community response having a single point of access now, being aimed at responding to urgent risks in the community and avoiding acute admissions where possible. And on the left-hand side of the diagram, you can look at the model at preventing and reducing risks through things like social prescribing, our full service, and further support through the voluntary community and social enterprise sector. Okay, thank you, Chaz.
Thank you, Steve. Is that the end or still? Yeah.
So I'm gonna...
Tanya?
Thank you. That's how integrated we work, you see. So Steve and I share these slides. He does my slide, I'm doing his slide, and we're working in an integrated way of working. So in addition to what Steve has said, there's a lot of focus on preventing people going into hospital in the first place. And certainly care at home, care in the community, and the neighbourhood health programme is absolutely the foundation of how we start to shift many people who go into hospital because, you know, either it's a last resort or it's on their doorstep, and we need to improve community care so people can see community as a place to gain care. And if they require acute intervention, so loss of limb or loss of life, those critical illness, they can go in without the long waits we're currently seeing. And that is a model that, you know, the national shift and all of our local shift and our commission and intentions, that is the focus. So I just wanted to highlight that alongside supporting discharge from hospital, we want to support the avoidance of hospital for avoidable conditions. And I don't mean avoiding hospital when you have a need. This is about avoidable admissions to hospital. And we do know that there is a number of conditions that if we manage much better in the community, then people will get first-line support, preventing them ending up in a critical situation and requiring acute care. So one of the new things, and we're here to talk about what else are we doing new to meet the requirements of NHS England to improve the discharge pathway, but also to ensure that we prevent avoiding admission where it isn't required, is we've commissioned this year the Neighbourhood Health Alliance, and that alliance is made up of all our big NHS organisations to start off with, but they will also have Memorandum of Understanding or MOUs with the voluntary sector and with the Hospice Alliance. And those NHS organisations include the Mental Health Trust, the Community Trust, and also include primary care in its biggest sense, so all of our primary care providers. And within that sort of commissioned process, what we want is to ensure that some of the transformation fund that I mentioned earlier supports that shift into the community to enable a 10% reduction in avoidable admissions. So, if we can do that, we then ensure that the access, so the delays discharges, we wouldn't see the number of persons potentially who require acute service waiting for periods of time, either waiting to go home or waiting to be seen or waiting in terms of the support they require within their, a bedded area or an acute setting, whilst the community services could pretty much mop them back up, take them home, support them at home, if that is in the person's best interest. Another thing we're doing, as I mentioned before, is the Highest on Ongoing Needs program, which is again commissioning the development of multidisciplinary teams that support complex cases in the community where it's possible and avoid hospital where it is avoidable. And that means more anticipatory care, more complex management. And it doesn't just mean looking at, I think Steve mentioned the Johns Hopkins, which is a risk stratification tool that helps to identify persons. It's wider than that. It's, what are the complex cases for adult social care? That would mean that if we manage that in a more multidisciplinary way in the community, we could prevent that admission in the first place, and then obviously not having to manage a delayed discharge because the services are not there in the communities. So just wanted to identify that that includes all of our major NHS providers, but also working alongside the VCSC sector and the Hospice Alliance, so that we can see that meeting the target is not the aim, but providing better care for people in the community and supporting a timely discharge if they do require acute care is the aim. And so we want to have a good sustained trajectory to that and strategically commission some of this, which then obviously means that we don't meet the target but miss the point for our community.
Have you finished? Okay, thank you. Thank you very much for your reports, which was very useful, and especially for the details about the plans to reduce admission and also to facilitate the discharge. I think it was very detailed and very interesting. Any questions or comments? Yes, please, Monica.
Yes, could I put a very contemporary slant on this and just ask everybody, with the situation we're in at the moment with influenza, if there is any particular activity that we're doing around vaccinations and so forth, and I look across the piece here, because it's not part of your report, but obviously it's really important where we are at this moment in time. So I know that's ait left of field, but I think it's really important because it goes to that bit where you're talking about avoiding hospital admission. Thank you.
Yes. Yes. Hope.
Yes. Thanks. I wasn't sure because we work so closely together and giving each other the eyes across the table. So I don't know if you were picking up my eyes, Steve, but I'll move on. So we do have, and the slide I had up on the screen did mention a 10 to 15% reduction, improvement in vaccination and screening rates, because we recognize it's a key one for us, and that includes the influenza vaccine uptake. And really pleased to report, because Brighton and Hove has always been an area that struggles to get the number of uptake that we would want to see, and certainly doesn't compare to the national picture, but we've seen early on in the sort of delivery of vaccines, and we work very closely with public health, very closely with NHS England, who delivers some of the vaccine program, the advice, the guidance around the delivery of vaccines. And we've seen really quick uptake in Brighton, particularly in areas that struggled with uptake before, because we're making the vaccination much more accessible. We're, translating the information in many more languages. We're trying to understand, some of what drives hesitancy, as we refer to, but also recognize that if people are absolutely not wanting to have the vaccine, then how they protect themselves. because it's about education as well as, it's not about ensuring that we hit the numbers of vaccines we need to, but actually that we're educating, supporting the communities. It's one of our top prevention aims in the neighborhood health. So the messaging, and if Jo was still here, she would say that every single health forum, they talk about vaccine uptake, they talk about the flu, they talk about keeping yourself well at home. Every single ICT meeting, again, vaccination rates are looked at, and each neighborhood look and compare themselves. So what are they doing well in that area? They've had an increase in flu vaccine uptake. How can we, sort of monitor and model what they're doing to improve in other areas? Thank you for that, and I think this isn't about pushing people just to have vaccinations, so thank you for that comprehensive response. In my day job, I'm a senior lecturer at Oxford University, and I've just had a paper published about the lessons unlearnt from COVID. And some of that is just some of the basic things, messages we could be giving people, which isn't just going back to mask wearing necessarily, but it is about social distancing, it's about hand hygiene. So I'm pleased to hear that those messages are still being across the piece, but I think, again, it's not just a primary care thing, it's all of us, I think, have a responsibility to give those messages back out there. So I think as much as we can do about the basic things that we learned from COVID, it is good.
Thank you. Any more questions or comments? Yes, please.
Thank you, Chair. Just one for Tanya, who mentioned the Neighbourhood Health Alliance, and whilst recognising the emerging importance of the SVLA in engaging with the voluntary and community sector, I wonder if the Alliance would be receptive to engaging with any other bodies, for example, a sector-led provider collaborative, as another means of engaging with what's a very, a vast and varied collection of different sized organisations.
So absolutely, in the Commission intentions, we have noted that we are expecting the Neighbourhood Health Alliance to have multiple subcontracts, and that will include with the VCSE sector, with the Hospice Alliance, but wider. With the private sector, even if that's what improves healthcare and delivers the support that we need. So I think it's mindful that although the core component of the Neighbourhood Health Alliance is NHS organisations, the local authority are a key member within that discussion of care and population health and outcomes. So I think this is just for 26-27. There are plans afoot, and if you look at the national programs around the sort of integrated health organisations looking at how we deliver care better, there is a lot of expectation that the VCC sector is going to be a strong member within the future development of those IHOs.
Okay, thank you. Any more questions? Any comments? Just like to ask Tanya. You mentioned about short-term recovery centers, which is one of the routes to facilitate the discharge, which is very good. But I wondered whether a reablement centers is in plan as well too, because we have only one, and you're doing a great job in Cavendale Centre. So, is there any plans of having more of those, because only one is? Yes.
Thank you, Councillor Baggot. Yes, in terms of the work around reopenment, we've got a new initiative in adult social care that's just started around developing a better reopenment pathway. So we currently have 16 beds in Craven Vale, which is one of our local authority care homes that provides a reopenment pathway. We've also opened 6 new beds in Arlen Lodge, which is again one of our council homes for dementia, that is providing a support around delirium pathway. And we have again secured some additional funding to revise our reopenment offer so that we give people a reopenment programme coming out of hospital as part of their hospital discharge pathway. But looking more upstream, we're also developing a reopenment offer for people that come to adult social care as a first port of call, so they get a reopenment offer before even going on to need care services. So we know that based on recent research, that our reablement offer in the city is lower than comparable authorities. So we have got some resources that we'll be putting into a new reablement programme early next year.
Yes. So any more questions, comments? I'll end the meeting, and sorry, I think we have gone over the minutes, but I think, 1 minute, not bad. I think all of you would agree that it was worth it. Very good meeting. Thank you very much for the great work. Yeah? Oh, sorry. Yes, I missed that one. I'm rushing. Yes. Because I had already agreed with it, I thought everybody had. Okay, so the recommendations are to not performance against Better Care Fund plan for quarters 1 and 2. Note the sign of the Section 75 agreement between the Council and NHS Sussex as one of the national conditions of Better Care Fund, and agree the revision to 3 metrics targets in our Better Care Fund plan for the second half of 2025-26 as part of final approval of 2025-26 plan, and note latest information on the national guidelines for Better Care Fund planning for 2026-27. Do members agree? Okay, thank you very much now. Good. Thank you.